When discussing local anesthesia is delivered topically where it can be applied to the skin or mucous membranes of the area that's going to be anesthetized, and it can also be done by local infiltration. So when you see think of local infiltration, as with this picture, you can see dental work, also sutures, stapling, any kind of small abrasion or laceration that might need some sutures. Sometimes when the term local is used, it means any form of anesthesia that is not general anesthesia. However, when we discuss local anesthesia, we're just meaning done for local infiltration, small areas. The patient will remain conscious, able to follow directions, able to converse with us, and things like that. With our regional anesthesia, the regional anesthesia is a type of local anesthesia. However, it will block several nerves in a specific body region. It may be used when general anesthesia is not because of medical problems. So your patients with many comorbidities may have to look at regional anesthesia. Typically, it is very good for pain control in the postoperative period because the regional anesthetics typically last anywhere from 12 to 18 hours. So it does have very good pain management after surgery. If the patient has eaten and say they're not able to undergo the general anesthetic, sometimes you might see these regional anesthetics being done. Type of regional anesthesia includes field block, nerve block, spinal and epidurals. And when you do your women's health rotation, hopefully you all have the chance to see the epidurals or spinal anesthetics being done on patients. They're becoming much, much more common. The definitions and common uses for these type of regional anesthetics can be found on page 275 of your IGGI book. So just take a peek at that when you're done listening to this slide, and we'll discuss it more when we get into class. This picture is found on page 276 of your book, and it just shows common sites for nerve blocks. So these will be areas that our patients may have anesthesia placed for pain management. The spinal and epidural anesthesia, you can see by this top picture right here, this patient is lying on her side, and that when the patient lies on their side, they sort of curl up in the fetal position, and what that will do is it will open up the space between the vertebrae, and then the needle can be placed between the second and third or third and fourth lumbar vertebrae. The patient is typically in that flexed lateral or fetal position as shown on that top picture. You might also see patients sitting up, and then they drop their chin to their chest and round their shoulders forward and push their back out. And by doing that, it looks kind of like, the best way to describe that is the mad cat. So when you've ever seen a mad cat, they kind of arch and round their back out. So you might see the lateral position. However, oftentimes you will see the patient sitting up, and then the chin being tucked onto the chest with that the mad cat-like position. After they get the patient in proper position, a large needle is inserted to the surface of the dura mater, and a second smaller needle is then passed through the first. So they leave that first needle in and then thread another needle through that first larger needle. Typically what will happen is they'll penetrate the dura mater and then the arachnoid mater. Once they get into this space, an anesthetic is injected. Sometimes, like with the epidural medications with laboring patients, or if you have a patient that has a large abdominal surgery, they'll leave that epidural catheter in place. And so if they do that, what will happen is you'll be responsible for helping the nurse anesthetist secure that catheter in place. It will run up your patient's back, come over the shoulder, and then typically it sits on the shoulder, and then it will be hooked up to an IV drip. So it's a epidural that's hooked up to a special machine that controls the rate. We're also seeing PCAs, being patient-controlled analgesia via epidural as well. Or you may just see the catheter and it's saline locked. And then with that, what they do is called a boost, and they'll boost that patient's medication to try to promote comfort during those first 24 or 48 hours post-operatively. The patient may complain of feeling like a quote-unquote zinger down one leg or the other. They might feel some pressure, just different feelings once that needle and medication is being inserted. Prior to the anesthetic being injected, the nurse anesthetist or anesthesiologist will look to ensure that there is clear cerebral spinal fluid that comes back through the catheter. So as nursing, I do think it's important to watch to make sure your anesthesiologist and your nurse anesthetist are waiting and ensuring that they have that nice cerebral spinal fluid, because oftentimes if they don't have that cerebral spinal fluid come back and they would just go ahead and push the medication in, your patient won't have good effects of that medication. And unfortunately, having been in practice for almost 20 years, I've seen several spinal anesthetics administered in the operating room prior to our moms having C-sections, and that anesthesia doesn't work. And so what we have to do is then stop, sit the patient back up. Oftentimes they've already been draped, so we have to remove those drapes. So it's just a really long procedure. So it's almost best sometimes if they know that somebody else is maybe taking a peek over their shoulder and watching what they're doing. So these are really great for pain control during labor, during abdominal surgeries, and things such as that. Complications of any of the anesthetics really, anaphylaxis, incorrect delivery technique. So that's when I kind of talked just a little bit about your patient where they don't have that cerebral spinal fluid coming back and they go ahead and inject, and then your patient doesn't have good effects. Quite possibly there could be a systemic absorption, and with that our patients will complain of itching and maybe increased fatigue, things like that. Overdose is always very possible that could happen, as well as just local complications at the injection site. So we do want to make sure that we are ensuring our patients are safe. So for nursing considerations, our role in the delivery of regional anesthesia is just going to be the assistant to the anesthesia provider. We want to observe for any breaks in the sterile technique, provide emotional support to our patient, always stay with the patient, talk to them, offer soothing words, tell them what you're doing, when it's going to be done, those kinds of things, and then positioning the patient comfortably and safety. So those are all going to be our responsibilities, plus watching for any of these complications. We can see respiratory impediment and airway failure if the epidurals or spinals tend to float up rather than sit down, or rather than flow down and anesthetize the patient that way. So we do want to make sure we are watching airway at all times. Treatment of complications: establish and open an airway. So if our patient has an overdose or that regional or block anesthetic is causing them to have difficulties with breathing, we want to make sure that we always establish an airway. Airway will always be first. Give oxygen, notify our surgeon, and then a fast-acting barbiturate is the usual treatment. If your patients have any unexplained bradycardia, oftentimes we'll see our patients' blood pressures and pulses drop after they've had a spinal anesthesia. You might see the nurse anesthetist or anesthesiologist giving them a little IM injection of epinephrine to enhance their sympathetic nervous system, sympathetic nervous response, and help bring up their blood pressure and heart rate. When we're talking about moderate sedation, what you may oftentimes hear from nursing staff is it's also called conscious sedation. With moderate or conscious sedation, we deliver IV sedatives, hypnotics, opioid drugs to help reduce our patient's level of consciousness, but it also allows the patient to maintain their airway. They can respond to verbal commands if you need them to turn, cough, anything like that. So some of the medications that you might see being used are amidate, diazepam, also known as Valium, Versed, fentanyl or Sublimase, propofol is really a good medication, and then just morphine sulfate, so a true opioid agonist. So the amnesia action is very short in duration. Patient will need a driver to get home from the hospital, but the selection of patients for moderate sedation is based on their criteria. So as far as what they're having done, the procedures, the comorbidities, things such as that. This can also be administered by a nurse, so it does not have to be administered solely by a nurse anesthetist or anesthesiologist. Typically, credentialed registered nurses can deliver moderate sedation because they are administering it under the direction of the physician, and oftentimes nurses working in surgery that administer moderate sedation will have advanced training in the IV drug delivery, airway management, and then ACLS or advanced cardiac life support. So when we are giving anesthesias, any anesthetics, we need to make sure that we are monitoring the patient for the response from the drugs, how they're tolerating the procedures. We want to watch their capnography, so looking at their carbon dioxide levels, oxygen saturations, have them hooked up to the telemetry monitor and be monitoring their heart rate or ECG. Vital signs are typically monitored every 5 to 15 minutes, and then once the procedure is over, they'll follow post-op instructions. The thing I would like to caution you about vital signs is that it won't always be every 5 to 15 minutes. When I ask you questions about checking your patient's vital signs, the thing that you need to be aware of is checking vital signs is oftentimes determined by your patient's status. So even though you have orders to check vital signs every 15 minutes, what are you going to do when you check it at 2 o'clock and the blood pressure is 90/30? Your patient has a bradycardia of 40. Are you going to wait another 15 minutes because that's your order? Or are you going to go ahead and take those in 5 minutes and see how the patient's doing? So we do want to make sure that we are aware that vital signs will be determined by patient status, not always just standing orders. This is a nice little pictorial image of moderate sedation. This picture is that they are giving Versed, moments not remembered. So when we give Versed, you can see in this picture that they are, using a colonoscopy or doing an EGD, esophageal endoscopy. And what we want to make sure is that our patients don't remember what happened to them. They will be able to tolerate the procedure much better with sedation. They'll be able to move around and have appropriate responses when we're asking them to do things. So for collaborative management, these are all, this is the nursing process. Nursing process always begins with assessment. So do an assessment of your patient, and we will talk more in depth about assessment when you come to class. We're going to practice doing preoperative and intraoperative assessments on each other. We want to make sure that we always identify our patient and validate that they've signed the consent, and then be sure to monitor them during procedure and then post-procedural. So these are just a few things listed out on this slide that you need to remember when you're doing your assessment. And like I said, we will talk more in depth about assessments when you come to class.